All right. Thank you, everyone, for joining us in another edition of COVID-19 Think Tank. We are at number 8, which is kind of hard to believe. So we've been doing this for 8 weeks. We are planning to continue for at least one more, hopefully 2, as interest keeps up. So thanks for joining. If you don't know, this is put on by the Society for Health Systems, specifically the Young Professionals Group. Again, my name is Allie Hobbs, and I'm the chair of the Young Professionals Group. So SHS in general has a mission to improve lives through better healthcare delivery. And we do that in a bunch of different ways, one of them being things like this think tank, but we really want to create this continuous improvement within healthcare organizations and cultivate this community so we can all come together, learn from each other, and hopefully have better projects because of it. So within SHS, there are various different communities that we'd love for you to join or be a part of. As I said, this is put on by the Young Professionals, but we also have experienced professionals, students, a clinical group, academic, and education. So if you're interested in any of those things or want to learn more, you can click on this link below, or you can reach out to anyone who's presenting today or myself. And what we want for today is this think tank to be really collaborative and discussing all the different topics. So feel free to ask comments in the chat, share your thoughts. You can take yourself off mute and ask questions that way, or you can also raise your hand and we'll unmute you for you. So feel free to ask questions at any time. Like I said, this is the 8th think tank, so we have had 7. We are recording this and we'll send it out afterwards, as well as the slides from all the presenters. So if you hear of anything that we're talking about that we might have said in another think tank, please go back and listen to it. We'd love to have your thoughts. In staying connected within IISE, we just wanted to do a little plug here to say that there's a crisis resource community online, and you can get there through this link as just another way to stay informed and keep this communication going. So today we have a great agenda. I'm very much looking forward to it. We have Mian Lee talking about the second wave detection post-COVID surveillance analysis. Then we have Lauren Cooper talking about getting a lot of feedback. Okay, sorry. I think we fixed it. So after Lauren, we're going to talk about the inside incident command center. So with that, I'm going to pass it on to Leon and let her share her screen and get this started.
Hey Nora, it looks like the feedback is coming from your account. Mute.
Okay.
Hello, this is Moyan. Okay. It sounds have any no.
Allie, can you guys mute? Just go ahead and read. Try again, Leon.
Okay. Are we good now?
Much better.
Okay. Thank you. Oh, can you see my screen now? Cool. Thank you. That's awesome. And hello, everyone. This is a great session. I have been participating a lot as an audience and also in the beginning, discussion. This is really fantastic to give everyone a chance to present what they are doing and also give everyone a chance to learn from each other. So today, I think thinking about where Florida State is at, this will be an interesting thing to present to the group as how at BayCare we're trying to track post the reopen, how the COVID-19 is going on, and how we continue our surveillance analysis, basically to prevent like a second wave or to try to predict what would happen. And to give you a little bit background, so BayCare is a health system with 15 hospitals and over 300 medical facilities across 4 counties, as you can see on the map. We have facilities across Pasco, Hillsborough, Polk, and Pinellas. It's really a large area. And we call it this 4 county as Tampa Bay Area. As you know, within this area, BayCare basically provide the community with access to hospital or ambulatory services, rehabilitation, and fitness, and so many other services. So we're really as a comprehensive, like a service destination, healthcare destination. So for us, like what do we care about? Because we have a market across these 4 counties, so we really want to focus to track how the pandemic, progress across this 4 county in Tampa Bay area. So as you can see, after the first case occurred in Hillsborough, March 2nd, 2 weeks later, basically Florida State announced a closure among educational facility. But after that, we really start seeing new cases growing faster and faster until March 26th. 2 out of the 4 counties in Tampa Bay area announced stay-at-home order. And that didn't really seem to really help to slowing things down. So the case is, still growing until April 3rd, the Florida State as a state announced a stay-at-home order. And 1 month later, 2 weeks, about May 4th, Florida really announced the phase 1 reopen. But if you see the time mark here, is that it seems like, okay, it slows down a little bit, but now we are seeing a minor spike, a minor increasing trend there. So for us as, PI or operational people, professionals, what we care about is like post the reopen, or if we assume we're already past the first wave COVID outbreak, are we going to have a second wave? And when, like, how should we know? How can we know, like, the second wave start happening? And also for that, like, can we do some sort of prediction to know like what we should expect? And that will help us to plan operation across different service areas. So those are the challenges, put up among us. And what do we think is like, if you really want to monitor the process, control chart is like the first thing occurred in our mind. So what do we try is that we just try to plot the new cases in Tampa Bay area with individual control chart, as you can see the left side. So basically, since the 10th case overall like happened in Tampa Bay area, we start plotting, and then it gave us an average. So this really helped us to give us like a quick overview, which, each data point is very interpretable because each data point basically is telling us the number of new cases every day. But it also tells us, a trend of like what's the average about 60 and a 3 standard deviation control limit. So it helps us to really detect larger shift in the mean. But if you think about if we're expecting a second wave, after so many months, like since March, I think the social distancing, the whole situation already raised awareness among public. So people should be more cautious when they, go outside. They would wear masks, and so we wouldn't expect like a large shift, like a standard deviation. We wouldn't expect a huge spike outside the 3 standard deviation control limit. So we sort of feel this individual control chart is very interpretable. Each data point is a number of new cases and tell us like trend, that kind of thing. But we wouldn't really help us to detect the second wave because we would expect the second wave start with a smaller shift. So that's why we combine the individual control chart with EWMA, which is exponential weighted moving average control chart. This control chart really allowed us to really create a 1 standard deviation control limit above and below the average. So that way, like if we do see a second wave, we will be able to detect the smaller shift. However, the cons about this chart is like, it's not interpretable anymore because each data point now is a moving average. It's actually, we give a weight. So we put more importance to the historical data than today's data. Because if you think about it, how the outbreak happens is like every time if we do anything, provide extra testing capabilities or social distancing orders, that won't really influence. Let's say if we stay at home today, like tomorrow we expect less case, not really. Like even the next week's case might be a result of how we did in the past 2 weeks, like we increased the lab testing locations or some other things. So we think this lagged influence will be perfectly captured with the moving average, because this allow us to take into consideration what happening in the past. And it also show us a nicer trend, so we can see a growing trend and a slowing down trend. However, this part help us to detect both large shift, smaller shift, and give us some sort of interpretation. But if you see, like, if you think about it, if right now, if we're going into the second wave, we would expect it doesn't make sense we have the same control limit, because if the control limit looking at what's happening since the beginning, then the outbreak's supposed to growing faster and then slows down, and then towards the end it should be like basically we wouldn't expect much growth there. So for us, if you look at this trend, it almost feels like there should be phases here. It shouldn't be one control. It should be like there is a phase that's growing, and there's a phase slowing down, there's a phase more stable or a steady state. So from there, what we're thinking is like, how can we really break this whole outbreak cycle or this epidemic cycle into different phases? And as PI, like a normal way we think about it is like, then each state should be basically separated by some process changes so far. And if you think about what could be potential process changes in this pandemic, it's like the social distancing, right? Like the new orders, now you can't really go outside, or now like people start working from home, that kind of thing. That's a process change. But if we start mapping out those changes, the social distancing on the chart, it doesn't really explain much. Like it doesn't seem like, oh, after the school closed or after individual counties announced stay-at-home order, it has any kind of changes. And I think that also makes sense because of the lagged influence impact on the outbreak. So the social distancing, and also there is a incubation period, all kinds of things really feels like even if you do any process changes, it doesn't really change our new case or process right away. So that's why we feel like this is not a good way. We would say, no, we are not going to use the social distancing, the date when we announced the social distancing new orders as the way to define new stages. So how can we do it? Then we really go back to the SRIR model, the pandemic model. We start thinking the pandemic should follow some sort of like pattern, like as it progress. And the first thing like we thought about is like it's just like population growth. Like it makes more sense, like the outbreak follows exponential growth. So after the first beginning period, when the cases occur randomly in random fashion, because there is a limitation of where you can get tested or medical resources, that kind of thing. At the beginning, after you're passing that random phase, pre-growth phase, then the pandemic will start going into a fast growth phase. So that during that growth phase, your number of new cases should really follow a growing exponential curve. And passing that, once you do social distancing control, or you do more medical testing, that kind of thing, then the case will start slowing down. The growth will start slowing down. So basically means the number of new cases will start decreasing. So that will be following an exponential decay curve. So if we plot it that way, then you can see it follows a natural curve. So that way give us a different type of way to calculate the control limit. So we think this makes more sense. And because how it happens at the beginning, if we assume the new cases happen in a randomly fashion, we think the C chart is a more appropriate for the beginning to renounce pre-growth phase. And how we define the growth phase is like, in this chart, you have the control limit. Once you have the first case outside the control limit, then we will define that's the beginning of the growth phase. And then we plot but basically the central line become the predicted average of new cases and following the exponential growth. And then we plot the eye chart. And then once, the new cases start falling out of the lower limit, that means you are not really in the growth phase anymore. So we say that would be a post-growth phase. And the same logic is like we're going to plot it, the eye chart. So we'll plot the exponential curve again, and as a central line as the predicted average case. So this way really allows us, but the logic is basically allow us, in the pre-growth, it's random, it's very, very low number of total cases, and then go into the fast growth, and then go into the post-peak is that the growth is slowing down, and eventually we'll start going into the steady state. So that's the logic. So we think after we presented this to the leadership, they said that makes more sense, especially the exponential curve and the growth and the decay pattern, like that makes more sense. So we think instead of using when the social distancing order was announced, this is a more logical way. So from there, what we plotted, we actually started with a Tampa Bay area. So we consolidated all of our market, the 4 counties, into a Tampa Bay area. So you can see in the previous chart, if you use the individual chart, you will see a whole bunch of alerts to say, oh, April 1st or April 3rd, you have a like abnormal growth, number of new cases outside the limit. There must be something going on. But now, once we start doing the phased or staged control chart, it doesn't, because it's supposed to follow the natural growing curve of the new cases or the pandemic. So now in this phase, there is nothing surprise us anymore. But actually moving into the post-peak, what we see is like there is something since April 8th till almost like May 4th, it's actually following the decayed curve. So it's like our new cases start dropping, the growth is slowing down. But something happened differently because now we saw more than 9 points consecutively above the central limit. So look like there's a sustained shift. Like we're not, the number of cases stopped dropping. Like they either stayed similar to previously or start growing. So we said, what's going on? This really helped us because in this post-peak air phase, we're supposed to, expect the new cases dropping and the control limit dropping. So now it actually alerted us, say something is different. And this helped us to keep drill down. So from the Tampa Bay area model, we drilled it down into all of our 4 counties. And that really helped us to find out the special cause, or to really do the root cause analysis, say what caused the growth in the Tampa Bay area. And what we found out is that actually we have 2 counties, Hillsborough and Pinellas, since early May, we have but we have significantly increased the number of patients who were in skilled nursing facilities and assisted living facilities, that they were tested positive and they were transferred out of those facilities into our hospitals. So that's why, or into our the general market. So that's why we start seeing the new cases there. And we believe the Tampa Bay increase was driven by the increase in SNF skilled nursing facilities in those 2 counties. And that actually helped us to really start a new conversation with our senior leadership to say, because at the time, Florida State doesn't have any way to really track skilled nursing facilities. They were not, there's no data to tell us where the patient come from, that kind of thing. So we actually share with senior leadership, and they share with Florida State to say, we need to start tracking, like those SNFs has to report their new cases every day. So to really start monitoring what's going on there. And that will be a key for us post the reopen. The good news is that right now we only see the 2 counties among our neighbors. Other counties, about like 9 counties around Tampa Bay areas, the cases are still following what we expected, the decayed pattern. But right now we're a little bit alert because recently we do see the beginning of the sustained shift, which is more than 9 points above our central limits. So we are very cautious about what's going on in our neighbor and continue to monitor it. But because, this pattern, because you can see the new cases actually fall between the 2 standard deviation and actually fluctuate around our predicted central line, which is the predicted average new cases, we believe that this model really helped us to monitor the new case much better fashion, and it's more interpretable and does less, alert about like above and below the control limits. So that's where we're now today. And moving forward, actually, this is just one part of our total analytics effort at BayCare since the outbreak, happened. We have 3 type of effort going on right now. Like I'm in the surveillance analysis part. Our next move is really try to break or separate our skilled nursing facilities data from our general consumer model. So we believe basically right now the overall community increase was driven by the SNF. So we want to separate that out to say whether the reopen has an impact on community or it's just like there is something going on in the SNF. And at the same time, previously I also was part of the predictive modeling. So we try to predict COVID cases in our community, but also do it by hospital. And moving forward in the future, we're looking into October or November season, how use some of the things that we learned since this pandemic to really build an influenza predictive model by then. So we will know what we should expect. And at the same time, on top of monitoring what's going on in the community, we also have a separate effort really looking at what's going on within BayCare. So we call that operational analytics. That's where we're really trying to track, patients' information or length of stay or ADT activities among COVID patients in our facilities. And we also, I think, the important things that we also tracking our screening effort, testing, and how the telehealth is utilized. So I think together, because we have so many people, this is a collaborative effort among our ADW enterprise data warehouse, strategic planning, marketing, and performance improvement. This is a collaborative effort of all these 4 joints, and then we present to leadership. This really helps us to have a grasp of, the BayCare experience and also the community situation. So I just put more information about the rules, how I really plotted the chart and for you. And the resources I use, really, I think Florida State provided excellent data access and transparencies to anybody who work in the healthcare community and also to universities. So all the data that I plotted was actually extracted from Florida Department of Health. They post data daily, so that's the raw data we pull into the Tableau. We pull customize the SQL queries into database. So we have like the truth of source, the source of truth there. And the general approach was actually introduced by IHI, this staged approach control chart. But for them, they only plotted till the growth phase. So they didn't think about the post growth phase, which will be the decayed curve. So I think that's very interesting, what I added there. Now I'm open for any questions you have.
Awesome, Leanne. Thanks so much. Yep. In the interest of time, I'm gonna throw it over to Lauren. There is a question in the chat though, if you wanna chat back. I think it might be a good way to keep the conversation going.
Okay. How did you decide when to fix the limits? Right, so C chart, yeah. So the C chart is basically when we have the very first data point outside the control limit. That's the indicator of ending of the pre-growth. That's how we decided. Any other questions?
Awesome. Well, thanks so much, Leanne.
Thank you very much.
Very interesting.
I'll stop sharing.
I think Lauren might have already stolen it from you.
Okay, that's good. Because I tried to find the button, stop sharing. Okay.
Can you guys see it okay?
We're having a little trouble hearing you.
Muted. Can you hear me?
Yes.
Okay, I get closer to my computer. Okay. Great. Okay, so I will talk a little bit today about our experience in delivering virtual training so far. So I talk a little bit about how COVID impacted our training programs, the pivot that we made to kind of land on trying virtual training, and share some of our lessons learned so far. And then, like Allie said, please use the chat box. I would love to hear what you guys are doing in this space. I know a lot of folks have pretty robust training programs at their health systems. So what we have, so I'm at Wake Forest Baptist Health. So we are kind of centered in Winston-Salem, North Carolina. I've got 6 team members, performance improvement advisors who help create and deliver the training offerings that we have. Our region has been very fortunate. We've had some hot spots in our state within Charlotte and Raleigh, but Winston-Salem has not been labeled a hot spot. Training accounts for only about 10% of the work effort that we do, but we have a huge broad offerings, and you can see this list here of some of the things that we've done over the last few years as the offerings that our training team does. So green belt, black belt, we have a consistent open enrollment monthly rotation of a performance improvement intro class and a team facilitation class. We've partnered with the med school on training med students and PI and patient safety and quality efforts. We get, one-off requested trainings here and there. We have a CPHQ training where we provide some guidance internally to our folks who are interested in obtaining that certification. And I will say Christy Vance is on the line as well. She's one of my PI team members and does a lot of training. So she'll jump into if she's got some extra comments. But we were really smack in the middle of designing a yellow belt program. So I'll flip to this next slide to give you the visual of where we were at. So the yellow belt program was going to refresh our PI 101 course and our team facilitation course. Those used to be full 8-hour in-person training efforts, and we were condensing those to 4-hour trainings each. And then we were going to add a data analysis course and a change management course for this nice little 16-hour bundle of courses to get yellow belt certified internally. And the only thing that we had ever really done virtually before COVID was that CPHQ training that I mentioned. And Christy helps lead that, and that was virtually kind of by necessity. We had some folks at our network hospitals who were interested in participating. So Christy was kind of able to adapt that material to be in person and virtual. But that was really our only experience with virtual training before all of this. So even though it's only 10% of our work effort, you can see at the time that COVID hit, we had a lot going on. So we all got sent home on March 17th. That's kind of the first little mark here on this red box. And everything in that red, that is what has been impacted so far. We were at the tail end of our black belt training. That was a small class of just 3 people who were kind of in their review and practice exam stage. So that was kind of really easy to go virtual. This IPE bar here is our interprofessional education event day, where we've partnered with the med school. And right when this hit and everybody went home, we had some conversations with our stakeholders and the planning team to discuss going virtually. And this is a really interactive event where med students spend the whole day going through an actual patient safety event that happened in our medical system, breaking up into smaller interprofessional teams with the med students, CRNA, APPs, and pharmacy students, and walking through that case together and really exploring the processes and where the deviations were, coming up with corrective actions, presenting to leadership at the end of the day. So we huddled for a little bit and thought the amount of time that we have to put together something very virtual and engaging and interactive was not enough time. So that event actually got canceled, and what we did instead was some of the presentations that we had throughout the day, those folks ended up recording a little session, a little on-demand session, and each of those programs worked that into their respective curriculum for that time period. So that was kind of low maintenance for our team. We just had somebody go and record a video real quick, so that wasn't too much. We do monthly lunch and learns, and those were also kind of virtual here and there, but given capacity of teams and folks and stuff, we've canceled some of those, but we've kept some of those going. But those are kind of like webinar type things that we do for folks in the quality department to kind of maintain their CEUs. But really the big chunk was all of our training refresh that we were doing. So, and our open enrollment offerings. You can kind of see where we were in the phases of updating our existing material and creating our new material. And so we flat out just canceled all of our in-person trainings for March, April, and for May. We had some pilots for our new team facilitation program scheduled in March and April, and we canceled those to try to figure out what our plan was going to be. And so when we were first sent home, I think my immediate response again was cancel, and like, wow, this is a really unique opportunity that we have to be at home. You know, some of our projects were put on hold because of all of this, and so let's focus on just developing the new material and work through the rest of, you know, whatever time it's going to be. There were so many unknowns back then of how long this was really going to last for. So the focus kind of shifted to, you know, let's wrap up the development of the data analysis and the change management course and kind of focus there. And, you know, it wasn't really until the end of April, our health system announced furloughs at that time. And I think that shifted our training focus again to where I think the reality of COVID kind of being with us for a while now kind of sunk in a little bit more. And so then we kind of had to pivot again and realizing, again, the reality of living with this for a while and how does this affect our training moving forward long term, even when we're allowed to go back to work, and should we, you know, we still have to be social distancing, and how does that impact the classroom? And what are the benefits of virtual training, and should we consider doing that? So at the end of April, we put a plan in place to test out our team facilitation material in a virtual environment. So I want to share with you a little bit of what we learned. And this plus Delta is hot off the presses. We had our session yesterday, and it was a very exhausting day, I'll be honest. We were testing the new material and testing the virtual training platform at the same time, so a double whammy of pilots going on. We ended up using the WebEx training platform. So our medical system has WebEx resources for us. And so we played around with the whiteboard features. We use breakout rooms, and they have an annotation ability to be able to highlight things on the screen as you're going through. Use of the chat feature was really, really helpful to keep people engaged and kind of keep the conversation moving. Specifically calling out participants. So we had about 8 or 9 people on our pilot, and our facilitators, you know, directing a question at a specific person was really helpful instead of kind of leaving it open for crickets. Having this producer and trainer role. So I have a link at the bottom here. I was actually listening to a ProSci webinar yesterday, and they coined this producer role. So having somebody who's in the background, who is helping to facilitate, helping to with the technology, you know, flipping back and forth from things, monitoring the chat box, helping with the breakout rooms. I don't know if anybody has used that feature before, but it's really cool to kind of break up into a couple of smaller teams to do some exercises. We took breaks often. That was another thing that the ProSci webinar suggested as well, and I think it worked well for us yesterday. Taking a 10-minute break every 50 minutes or a 15-minute break every 60 minutes. And then again, we tested this with a small group of internal customers, and I think that was a good way for us to go initially, instead of opening it up to the whole, you know, medical system and having external folks join that call. Think that we could have done better. You know, like I said, WebEx is offered to us internally, but there's a lot of other tools out there. I know Zoom has similar features, but might be more intuitive in the way that the platform is set up to use. Poll Everywhere is something that the ProSci people mentioned yesterday as another tool to really engage with trainee members. The participant materials. So we emailed things out to people, but given our at home, some people had it on their screen and some people printed it out. You know, so some people were trying to balance a whole bunch of things on their computer monitors. So just realize, you know, making sure everybody has the materials they need, and if it needs to be in their hands, you know, can we ship it to them ahead of time or something like that. We did have a stretch in our program where we didn't have a lot of exercises and a lot of engagements. Keeping in mind that people's computer setups are differently. So when we're testing this out, if I have 2 monitors, not everybody at home is going to have 2 monitors, and just being aware of the at-home environment for folks. People were not always using their camera, and we definitely needed some more practice, I think, with the tools and the material. And my biggest takeaway from all of this was we took our 4-hour condensed new material and put it into the virtual environment and tried to make the virtual environment fit that new material. And I think if we had done this differently, we would have been a little bit more intentional about altering the material to fit the virtual environment. So really thinking about how you can use different tools to engage audience members. That ProSci webinar also mentioned that you need to be engaging folks every 5 to 6 minutes when you're doing a virtual learning session. So I think that's kind of my biggest takeaway for the next time we do this. So just some high-level thoughts of where we're at with this whole program. You know, again, I think there's a lot of benefits to virtual training, with our health system being, you know, we're a 5-hospital system across part of Western North Carolina. Our training is really headquartered in Winston-Salem. So being able to offer virtual training, even after COVID goes away and it's not a concern anymore, we'll be able to expand our reach and reach more folks in our system. Yeah, again, we'll have an opportunity for in-person training again with proper social distancing. So even thinking about, we haven't tackled that one yet, of how that's going to look of the classroom environment with everybody spread out. You know, we can't really have people working together on top of each other anymore. So we need to think through that a little bit. And then, yeah, ProSci mentioned yesterday, again, the virtual learning is fundamentally different than in-person learning. It definitely requires more intention and preparation. Building that virtual toolbox of all of the different tools available in these different platforms and how you can use them to engage remote learners, just needing to be really intentional about that. Okay, so again, to Allie's recommendation, please use the chat box. I would love to learn from others and what they're doing in this space. And I'll put my email address in that chat box too if you want to continue the conversation after this. But thank you so much. Yeah, we did, Eddie, we did a 4-day or 4-hour, 4 hours of an online training class. That ProSci webinar, they have had to go complete remotely for all of their training. And they said they have done 3 days with 6 hours each day for their ProSci certification program. So they are more than just an hour at your computer at a time. So we just did 4 hours yesterday. Yeah, simulation pieces, how to do that. Right, that's so hands-on. And I don't know how to make a hands-on training like that go virtual, but I'm sure there's a way to figure that out. But you have to be intentional about it, and you can't just make what you've done before fit the virtual environment. You've really got to be intentional about adapting it to that new environment. Cool, thank you.
Thanks so much, Lauren. And we have her email as well as all the other speakers we'll be sending out in this presentation. So if you want to connect more or have more questions, please follow up. And with that, I'm going to pass it on to Annie.
All right. Hi, everyone. Happy Friday. Thanks for sharing part of your afternoon with me. My name is Annie Schutt. I'm a transformation manager for Sinai Health System, which is located in Chicago. And I'm just going to give you guys a little bit of information about being inside the Incident Command Center during my health system's COVID-19 response. There we go. A quick background over what I'm going to go over. I'm just going to give some background on my health system and kind of how COVID is affecting our area and the population that we serve. Then just some quick background on the Hospital Incident Command System, which is also called HICS. And then I'll talk about 3 specific initiatives that I was a part of in my time in HICS. So Sinai Health System is located in Chicago. We serve the west and southwest sides of Chicago. We're the Trauma 1 kind of located closest to where a lot of the gang violence in Chicago occurs. And we're a safety net as well. So a lot of our patients are uninsured, underinsured, or not insured at all, which means that I know a lot of health systems are now facing financial trouble due to coronavirus, but this isn't really due to us. We really struggle getting resources and have to think of creative ways to make sure that we're delivering quality care to our patients at a low price. A little more background. So we have 2 acute care hospitals. One is this Trauma 1 hospital that is pictured right here. And then we also have a hospital further south that isn't Trauma 1, but it receives the most ambulance runs in the state. So between those 2 acute care sites, we get over 86,000 emergency department visits every year. We also have a rehabilitation hospital, which really partners with our Trauma 1 and getting patients, especially kind of from the gun violence, back into the community and learning kind of how to adjust their life after a gunshot wound.
Annie?
Loser?
Might have lost her. I will get in contact with her and let her know. But Lauren, I did have another question really quick on, is there any consideration on who would be the best candidates for virtual versus waiting for in-person?
Good question.
It's hard to hear you.
Sorry.
I think I got kicked off, but I'm back. So
Yay.
back, and then we'll do screen share. Sorry, my internet's a little not very trustworthy. Here we go. All right. So Illinois is the 3rd most hard-hit state in the country, behind New York and New Jersey as far as the number of coronavirus cases. We're just under 100,000 right now, and about 2/3 of those are within Cook County, which is where Chicago's located. Chicago is really the only big city in Illinois, so it makes, Chicago's 1/3. Just kidding. But yeah, so we're most of the cases are happening in the Chicagoland area. Sinai saw our first case in mid-March, which is kind of early. We were expecting, just because of the patient population that we serve, that we kind of had more of a delay, because initially they were saying it was just people that were able to travel internationally and that would be seeing the virus. And we we saw some of the earliest cases in the state. And to date, we've had about 650 patients that have had inpatient stays within our 2 acute care hospitals. So in mid-March, we deployed the hospital incident command system. The HICS model is basically just a standard to approach any disaster emergent situation. So an example of something where you'd have a really short HICS would be a power outage. So you would just pull someone, you have your incident commander, and then basically under that, you have these 4 main umbrellas, which are operations, planning, logistics, and finance. So a power outage, you would probably have a single day for this, but for something like a nursing strike, it would be multiple days, it might last weeks. Coronavirus falls into the second bucket where it was a longer term incident command. So it wasn't 24-hour, but it was every single day. We were looking at different problems across the system and rapidly responding to them. So I would kind of refer to HICS as just a lot of rapid improvement events that are back to back to back. Also, the structure that is traditionally taken for HICS is having everyone sit in the same room. So logistics will be at that table, finance is at that table, planning's over here, and operations is in there as well. And so that was an interesting challenge that we had as well, because we had days when we tried to be remote and tried to do everything virtually. But we were definitely more successful in times when everyone was in the same room, because you can quickly, if you have an issue, the person you need to talk to, the person who's making decisions is in the room with you. Also, every single person who serves in a HICS role abandons their standard job responsibilities. So if I was working on, let's say, a sitter reduction project, that doesn't matter while I'm serving in HICS, which I think is important just to know that whenever you have a disaster response, kind of everything falls wayside. So one of the larger initiatives that I worked on while working in HICS is the rapid mobile assessment trailers that we had. So like a lot of health systems, we were facing issues with when people were coming into the emergency department, if they were at risk of having COVID or we found out that they did have it, we didn't have a process in place to isolate them immediately. And so we wanted to design something so that we didn't have patients with other issues sharing a waiting space with patients that were suspected COVID cases. And so what we did is we built these trailers and they were negative pressure, and we created an outdoor waiting space. So we did quick registration and an initial triage outside just to kind of, keep the air separate for everyone. And we gave ourselves 2 weeks to have this go live, which sounds like a really long time, but that included obtaining and building these trailers. So part of the work that I was involved with was designing the process that the patients were going to go through. So the space that we decided to do this in was our ambulance bay. Luckily enough, it had been under construction for about 2 months, and it was supposed to open early April. So our ambulances were used to another process for drop off, where they kind of were using this sidewalk area that we had put aside for them. And so we had a perfectly usable space that we were able to quickly flip. And so then we just needed to talk through the process. So I worked with our directors within the emergency department and our registration team. We talked a lot about staffing, but then we were able to kind of design this process, which is just looking at when the patient arrives. You'll see there are 3 different points in this process where the patient is sent to the emergency room. So we wanted to make sure that even though we're looking for COVID cases, there are obviously going to be people who need more urgent face time with the physician within the hospital. And so we built those checks into this process to make sure that nothing fell through the cracks. But yeah, worked as a team to design this process and then piloted our go live. Everything kind of fell into place after that. So here are some pictures. The left-hand side is a tent, which is where we did the quick registration and kind of an initial triage from the nurse who was helping with the documentation. You'll see there are 2 computers there. One of the problems that we had was we didn't have Wi-Fi extenders outside. So initially we had a little bit of connectivity issue, but then we were able to, once we realized that, work quickly. Everyone's in that same room so we could get everything installed before the go live. The picture on the right-hand side is our trailer. What you can't see, so you can see the exam room on the left-hand side, and then on the right-hand side, there's another door. So that's our staff-only door. Each of these trailers had 3 rooms. And so the middle and right-hand side room were our clean rooms. So our physicians would kind of work their way through, and that way we could give them space to put PPE on, but we also isolated the patients in keeping them in that exam room and not contaminating the space where documentation was happening. We also had to work to get, you'll see those sinks. We had to get those connected to water. So there was a lot of work to get everything up and running. I was joking with my sister who works in marketing. She kind of does pop-up events. And I was like, I feel like you right now, I'm just running around trying to make sure everything's in place for go live, which is something I hadn't really experienced in other rapid improvement events within the hospital. Another initiative we worked on within HICS was the communication boards. So I'm sure all of you have been experiencing this, but from coronavirus, it feels like you're just constantly bombarded with emails. And we realized a lot of our frontline caregivers don't even know how to access their email addresses. Obviously, that's a huge problem and needs to be addressed, but it wasn't our immediate concern. Our immediate concern was making sure that the messages they need to see are available to them. So the solution that we came up with was just creating communication boards. This plan was 10 a.m. It was thought up and we needed to have it done by 5 p.m. So this was a lot faster and you'll be able to see kind of the rapid response to this was more important than the quality. So in that day, we decided we would break down our news briefings into 4 different areas: news and numbers, PPE and supplies, employee resources, and clinical and departmental guidelines. We assigned an owner to each area and went through emails and kind of found 8 documents that fit each of these areas. And then we went live, but each of the content owners at any point and since then have been able to send us updates. And we work with the managers of each of the units to update these boards. So from that idea to what they ended up looking like, as you can see, it's not super glamorous. We just used a plotter to print kind of poster boards. And then we used plastic sleeves that you might find in like a binder to hold pages in place. But it got the job done and we were able to do it in a really rapid timeline. Another initiative we worked on, this is actually through SHS. So from one of these calls, AJ reached out to me afterwards and mentioned that she had a contact in Chicago who was working with a network of people that had 3D printers across the Chicagoland area. And they were all making these face shields. As I said before, Sinai doesn't have a lot of resources. Our financial situation was pressed long before this. And so these were all provided completely free of charge, just donations to our front line. But I worked to help get these donations on our caregivers. So this group has made over 20,000 shields, all passed out around the Chicagoland area. And we've received 1,200 of those. So here are some of our caregivers. From updating the communication boards, was able to get these pictures. But that was a really cool group to be a part of, and it was great to see people banding together, which I'm sure everyone has seen things like this on social media, but it was great to be a part of it. So that's just a little background on the HICS model. If anyone has any questions, feel free to reach out to me. This is my email address, and we also have some time for some questions.
Great, thanks, Annie. We do have some time for questions. You can ask Annie or any of our speakers today questions. You can do it in the chat. You can come off mute and we can hear your voice, whatever works for you. I think I've let the awkward silence go long enough. So, like I said, we have recorded this. We will send out the slide deck along with the email addresses of all of our presenters today, which thank you again, presenters. This was a really great think tank, and we look forward to seeing you all next week. Have a great Memorial Day weekend, everybody.
Thank you very much. Have a good weekend.
Thanks, everyone.